All right, good morning. We could get started for the Wednesday, March 11th EMCC meeting. And we can start with call to order and introductions and start with members in the room.
Please make sure your microphone.
Jody Schaefer, citizen rep.
Kurt Shockey, citizen rep.
Carla Spencer, nurse administration rep.
Good morning, Deborah Hopgood with the EMS agency.
Will Hiller, AMR operations.
Steve Brooks, EMS agency.
Marie Lutz, Natividad ER.
Leslie Oliver, Emergency Communications.
David Sargenti, Monterey County Regional Fire.
Chris Berkwin, Delray Oaks.
Karina Moreno, EMS agency.
Kimberly Hernandez, EMS agency.
Christina Torres, EMS agency.
Manashwini Jagir, EMS agency.
Devin Delaney, EMS agency.
Justin Lindquist, Monterey County Regional Fire.
Daniel
Stephen
Fry, Fire.
Mike Esslinger with AMR.
John Burley, EMS agency.
Jalen Neal, EMS agency.
Okay. All right, we can move on to public comment. Any member of the public may address the committee for a period not to exceed 3 minutes. Any issue not on the committee's agenda, the EMCC may listen to all communication but may not take any action. Is there any public comment? All right. Hearing none, we can move on to approval of past EMCC meeting minutes from the January 14th, 2026 meeting.
I move we approve it.
Second. All right. And approved. Do we have to take a vote, Steve, or is it just approved? Sorry.
We can do whichever voice vote.
Okay.
Accept or not.
All right. All in favor? Aye. All right.
Opposed.
Opposed? All right. Seems approved. All right. Moving on to standing reports. Item A, EMS Director.
Hey, good morning, everybody. I would like to start off this morning by introducing Christina Torres, who is the newest member of our team at the EMS agency. She joined us a couple weeks ago. She's been a county employee for some time now. She previously worked with the Social Services Department and the Behavioral Health Bureau, most recently as a part of the crisis response team. So we're thrilled to have her on the team, and you'll be hearing more from her as she starts taking on her own areas of programmatic responsibility and reaching out to external stakeholders. So Christina, is there anything that you would like to add?
No, thank you.
All right. Also, we, as of yesterday, have posted for 2 additional EMS analyst positions. In an accomplishment, we were able to post those as open until filled so that we will be able to, on a cycle, screen applications and move forward without needing to repost, which will allow us to speed up the process. The priority screening date for the first set of applications is March 22nd, 2026. So please, if you know anybody who may be interested or would be a good fit for the EMS agency, please feel free to forward the information to them. And also, as far as staffing, Devin Delaney, who is our temp, previously an agency temp, has been able to transition into a county temp position, which allows him to work more hours with us and also to be with us for an extended period of time, which is he's been a great assistance to us with several projects. So it's nice to have him for those additional hours at this point. Otherwise, we have been working on several agreements. The board yesterday approved the agreement between the EMS agency and Salinas Valley Health related to base hospital services. We're also working to finalize agreements with Natividad and CHOMP for their base hospital services. We're working with ESO to do a 2-year extension of their agreement. And then we are also working with Natividad to extend their trauma designation agreement for another 2 years as well. We have also moved forward with the implementation of CERTME, and I believe Steve is going to be talking about that later. Yes, he is. So I will hold off on any additional comments related to that. Also at yesterday's board meeting, our 2025 EMS annual plan was approved by the board. Just as a reminder, that's a statutory requirement put in place by the state. So we are required to provide an initial EMS plan, which was done many years back, obviously, and then provide annual updates on the go forward. So that will next go to the state EMS authority along with our STEMI stroke, trauma, and general QI plan annual updates as well. Also at the board, we had a new EMCC member appointed. So John O'Brien will be joining the EMCC on the go forward as a citizen representative. The agency staff is working on our annual report to the Board of Supervisors and our plans for EMS Week. Our goal this year is to implement a community education outreach effort. So we'll be working on that and more information will follow. In the background, the revamp of our website is also ongoing. So that's anticipated to wrap up somewhere near the end of the year, early 2027. And then finally, I will extend an invitation to any of the agencies that might like to join us and public health staff for the upcoming California State Patient Movement Tabletop Exercise, which is a mouthful. I sent out the invitation previously. It's scheduled to take place on Thursday, March 19th at 8 a.m. We'll be meeting in the time room here in this building, and anyone who would like to is welcome to join us. So that is all I have for updates now. I'm holding off on anything related to the ambulance agreement because that is covered later in the agenda. So happy to answer any questions. So.
Thank you, Deborah. On to item B, EMS Medical Director, Dr. Burley.
Thank you. So the Clinical Care Committee met earlier this morning, and a few things from that. We heard from Kimberly regarding ambulance patient offload times. In general, the hospitals are within compliance, which is great. All hospitals were within the appropriate compliance for January. And our data, we were having some challenges in terms of getting our data to sync with the state's data. So I'm happy to say that the data appears to be syncing well within about a 5% threshold, and so that's moving along nicely. We heard from Steve regarding the 2026 policy and protocol review cycle. As you're probably aware, we review about a third of the policies and protocols on an annual basis. And for the 2026 review cycle, we're wrapping that up. We did have an action that was taken with endorsement by the Clinical Care Committee this morning for the 2026 policy and protocol review cycle, pending two protocols that involve air medical transport, which we'll bring back for our next CCC meeting for ultimate approval and discussion. We also heard what may be the last report on AB 40 for a while and AB 40 implementation. We heard that the nurse navigation program is moving along well and it should be implemented shortly. And then we got a little taste of the 2027 policy and protocol review cycle, which we'll be initiating for this upcoming year. We have been transitioning into electronic applications for EMT certification and paramedic accreditation, which is going well and should hopefully speed up the process. We also had received a presentation from Susan Duke at CHOMP regarding post-birth alert bracelets that CHOMP is utilizing for postpartum mothers, such that they wear a bracelet over the course of at least 6 weeks and maybe up to a year following birth, so that EMS providers who encounter those patients can be alerted to the fact that they are postpartum, which increases their risk for certain pathologies. And the bracelet actually has a QR code that can be scanned, which brings up further clinical information, which can be helpful in developing a differential for patients having clinical symptoms. We also heard from Deborah regarding the CQI tag, and we concluded the meeting earlier this morning. I'm happy to answer any questions that the group may have regarding any of those items. Thank you.
Thank you, Dr. Burley. Deborah, item C, Mohawk.
Yes, so February and early March have been particularly busy times for the Mohawk program, with a lot of efforts related to exercises and various tabletop exercises and the like. We served as an evaluator for a recent public health shelter tabletop exercise. Worked with that group to provide some feedback on their efforts for sheltering. We also participated in the Car Week tabletop exercise, and then a earthquake preparedness tabletop exercise for the region that was put on by the Association of Bay Area Health Officers. And then we participated finally in the Healthcare Coalition's medical response surge exercise as well that took place recently. We're continuing to work with the Healthcare Coalition on planning for the functional and full-scale exercise that's scheduled to take place on April 1st. And then, as mentioned, please feel free to join us on March 19th for the patient movement plan exercise. So finally, I will, for the facility reps in particular here, we recently published a request from the region related to the availability of measles treatment medications. So it's a real quick survey related to what you have available at your facility. So if you haven't done so for your facility, please make sure you complete that by Friday is when they're looking for the information. So that's all I have for Mohawk, unless anybody has any questions.
All right. Thank you, Deborah. All right, on to EMS system performance metrics. Item A through E, Kimberly.
Good morning. Okay, so I'm going to be up here for a little while, so bear with me, okay? Quite a few things to get through. So going to do it a little different than we have in the past. Usually we always include all of the reports in the agenda packet, but I am going to bring them up for this meeting because we do have a new member to kind of go over some things and explain or answer any questions. So first we have 800 megahertz radio, and while Karina is bringing that up, so monthly, the EMS agency collects data that AMR dispatch is tasked with doing drills or testing on first the 800 megahertz radio. So that's kind of like a redundant radio to keep in communication with the hospitals. And so they test that daily and they notate if the hospitals responded or did not, because of course, during an emergency, we want to make sure that the hospitals have this radio accessible, that it's plugged in, that it's working. So those drills are done daily. So this is the compliance for that. We're looking at December and January, and you'll see, Chomp, Memorial, Natividad, Salinas Valley, and AMR, and then the standard, we're trying to get it 90%. I'm sorry, 95%. It shows if AMR didn't conduct the tests. So like for December, AMR conducted the test 87% of the days, and then 100% for January. When there is a dip in the compliance for the hospitals, prior to reporting it out to the committee meetings, I receive the results and then I communicate with the base hospital coordinators to find out like if there was any obstacles. Sometimes like there's been times where the phone got unplugged accidentally, or they've had travel nurses that didn't know that they needed to answer the phone. So anyway, we keep in contact with the hospitals just to kind of keep on top of any dips in compliance. The next one is also a drill that AMR conducts daily, which is ReadyNet. ReadyNet is an online platform that is another way to communicate with hospitals. Specifically, it's mostly used for here if there is a multi-casualty incident. So this is drilled daily by AMR for the they send out a MCI drill so that the hospitals can respond to it. They respond with how many patients they could take if it were a real MCI, because of course we want to make sure that this, like I said, it's an online platform. We want to make sure that the hospitals have it up, that they are able to see it and hear it if an actual MCI were to come through, because it is a great tool for communicating with the hospitals during an MCI, because it allows them to know, dispatch to know how many patients each hospital can take, and then they can provide updates through this system without always having to make phone calls. So this is their compliance for response. Again, just like the 800 megahertz, I receive these monthly, and then I communicate with the hospitals if there are any dips in compliance to find out. Like one hospital told me someone had turned off the alert, so they weren't hearing the alert. So these are things that we catch so that if there is a real incident, you know, of course they can still use the phone, but these are systems that if for some reason the phone wasn't working, they provide a lot of backup. So moving on, any questions on that?
That's the 95% threshold.
Oh, go ahead and just punch here. There you go.
Who sets the 95% threshold, and is it a requirement, and is it an average, or is it every incident?
It's 95% is like the goal. So it's in our policy to have 95% compliance. I'll tell you that it's not regularly at 95%. But there was a goal that if it got to 95%, then the drills would be done weekly versus daily. It hasn't really gotten there. So we just keep doing it daily, but that was just set in policy, and it's a goal to make sure that the hospitals have those systems up and ready and are able to respond to them, because if in an emergency that we needed to use it for real, not for a drill, they need to be able to answer. So, okay, so this is contract compliance. So I'm going to go over this slide first. So ambulance response times by zone, and keep in mind for everyone, this is the last month that we'll be reporting on AMR's compliance according to the old contract. So this is going to be through January 2026. And then when we meet again in May, we'll be into the new contract. So I won't do a ton of detail because it'll change a little bit when we go into the new agreement. Even though we're currently in the new agreement, we're still reporting on the old because we haven't gotten the new compliance for the new agreement yet. So there are zones and then there's priorities. So each zone, so I'm going to go, green is kind of like an urban zone. Yellow is more suburban, and then orange is more urban, and then red would be considered like wilderness. So that's why you'll see the response time is as soon as possible. So these are going to be areas that are going to take a very long time for responders to get to, but they are coming as fast as they can, but there is no technically response time requirement for those areas. But you'll see priority 1 are the highest acuity calls, and they have the shortest response time for each zone. Priority 2 is so priority 1 is lights and sirens. They can't be diverted to another call. A priority 2 is a call that is lights and sirens, but technically could be diverted to, so if an ambulance is responding to a priority 2 call and they end up being closer to a priority 1 call that comes in, they can be diverted now to that priority 1 call. Priority 3 is a code 2 call, meaning no lights or sirens, which can be diverted to a priority 2 or a priority 3 call. So the least restrictive of the response times. Priority 4 through 7 are what are priorities for interfacility transports. So priority 4 is a scheduled transfer. Priority 5 is an immediate transfer. So let's say a hospital needed a rapid retriage of a patient and needed them code 3. That's the response time in the green and the yellow. And the reason why you don't see orange or red is because we don't have any hospitals in the orange or red zones. Priority 6 is what is a critical care transport. That's the scheduled pickup time. And then priority 7 is immediate. Keep in mind for priority 6 and 7, like I said, it's critical care transport. There is only one critical care nurse in the county because the call volume is very, very low. So those are for those really high acuity patients. And so they meet up with an ALS ambulance and response. So technically, If a CCT is tied up on a transfer, the next one is going to have to wait. And there's other things that can be done if needed, if the patient needs to leave the hospital quicker than the CCT nurse can get there. And any questions on the response times? Okay. Go ahead, Karina. So this is response time compliance by overall priority, 1 through 7, and you'll see the line is at 90%. So AMR's contractually obligated to be at 90% or more compliant for their responses within each zone. For December and January, all reportable priorities were at 90% or higher. And when I say reportable, there is a provision in the agreement that within each zone, and you'll see in a slide or two, there's some zones that the call volume is very low per month. So it would be unfair to calculate it. Let's say there's only 5 calls and one's late. Well, they're going to be out of compliance. So the calls have to get to 100. So if that takes 3 months, then that's when the compliance is calculated. So once we get to 100, the month that it turns 100, whatever calls are in that month, be it 20 extra. So if it's 120 responses, that's when the compliance is calculated. So that's called the 100 call rule. Next slide. So this is going to be a response time compliance for green, which is the traditionally urban zone. There was one that dipped below 90% in December, which was priority 3. I will tell you that sometimes, and not a lot, and you can see it hasn't been a lot, but priority 3 tends to sometimes get in that lower because those calls are being diverted. So like if a priority 3 call is they're en route to that, they might get diverted several times. And then the next call, the unit has to go to the priority 3 call because they keep getting diverted. So sometimes the response time can get extended because we're doing what priority dispatch should do, is sending the closest resource to the higher acuity calls. So they were at 89% for that in December, but in January, everything was well above 90% for green. Next slide. Response time compliance yellow, December and January, everything was either at or exceeded 90% compliance. If you don't see it on the slide, the priority, that's because it did not meet the 100 call rule for the month. Next slide. Orange, which is the urban, you'll see it's more spread out because the call volume is lower in those areas. So there's some months that it's not reported for, or it could even be a couple of months depending on the priority. For November, none of the priorities were reported because they had not hit the 100 call rule. But in December and January, you can see that they exceeded 90% compliance for the orange zone. This is medical priority dispatch system performance. Each call that comes in for ambulance service goes through the emergency communications department, and then it is decided if it's either a fire, police, or medical call. The call is then transferred to AMR dispatch for emergency medical dispatch prioritization. So the call goes through what we call the EMD process. So what this is showing is, so when the call goes through the EMD process completely, you get a determinant code. And that's what bases on if the call either gets upgraded, downgraded, that sort of thing based on the acuity of the call. You'll see there's a delineation. So for each month, we also adjust the call volume when we're measuring EMD because there's a lot of calls that never end up in AMR's queue because they will never be EMD'd. Interfacility transports, structure fire, those are calls that would never need to go through the medical priority dispatch system. So we remove those and we try and get to like the truest amount of calls that could potentially end up in AMR's queue. And even some of those don't end up in there because as Leslie well knows, there are calls that have a police or a scene security component that are not going to get sent over because they are her team is interrogating the RP, be it a shooting, even though a person is shot, the scene safety is highest priority. So they're going to hold on to that call and AMR is never going to get a hold of it. So out of the calls that they potentially could EMD, that's what we're measuring. So we're showing that for December and January, they were at 74%, meaning there was a determinant code assigned to that call. And 75% for January. And then the top number, what you'll see is that the call was aborted sometime during the EMD process due to help arrived, meaning that fire arrived, the police department arrived. We wanted to kind of give credit to AMR to show that they EMD'd the call up until the point they just couldn't do it anymore because help had gotten there. So they would have gotten a determinant code, but help got there before they could get it. So overall in December, there was 77% of calls were EMD'd up until the point they couldn't be anymore, and then 76% in January. Any questions? Okay. Ooh, that's it on that one. All right. The next one I have is the fire-based ambulance report. Karina's going to pull that for me and I'll go into that a little bit. So the fire-based ambulance report is there are 2 jurisdictions in the county that are outside of the exclusive operating area, which is AMR's area for ambulance response. They're considered what's called a 201 area. So they have kind of grandfathered in to have ambulance response. That's part of Monterey County Regional Fire District's area has ambulances, and also the city of Carmel by the Sea has an ambulance. So this report is showing they don't have any specific response time compliance or requirements, but it's just an informational report kind of showing what Carmel Fire Ambulance did. We do it biannually, so how many calls they responded to, what their 90th percentile time response time is in different areas. So for this right here, what we're looking at, this is going to be their total calls, which was for January through what we do it in 6 months, and then we do it at the end of the year. So this is the one that's at the end of the year. So for the total of 2025, Carmel Fire Ambulance responded to 1,109 calls with an average 90th percentile of 12 minutes and 24 seconds for approximately an average of 92 calls per month. You can scroll down a little bit, Karina, please. We also go into kind of divvying up, like Carmel Fire Ambulance responded to 660 calls within their CAD designated response area, meaning that's their technical response area. And the average 90th percentile time was 10 minutes and 59 seconds with approximately average of 55 calls per month. And then we go further into separating it out into how many they responded to that were mutual aid. So that was calls outside of their designated jurisdiction. So they responded to 449 mutual aid calls with an average of 90th percentile of 13 minutes and 20 seconds for approximately average of 37 calls. Oh, can you scroll up, Karina? It's the one, right? That one. Yeah, thank you. 37 calls per month. And then you can go down to the next one. And then we also just look at any calls that were within the city limits of Carmel by the Sea. And that was 499 calls with a 90th average percentile time of 5 minutes and 20 seconds for approximately an average of 42 calls per month. And then going on to Monterey County Regional Fire Ambulance, they responded to 1,145 calls through 2025 with an average 90th percentile overall. This is all of their calls, 17 minutes and 4 seconds for approximately an average of 95 calls per month. You can scroll to the next one. Within their CAD designated response area, their 90th percentile time was 14 minutes and 64 seconds with an average of 64 calls per month. And then the mutual aid that they responded to outside of their area the 90th percentile was 23 minutes and 2 seconds with an average of 31 calls per month. Any questions on that? All right. Now we're going to do South County ambulance response time. So while Karina pulls that up, this has been a report that we started doing a few years ago to look at different areas of the county. There is not a response time requirement for specific areas or cities or communities. They fall into different zones, but this is to kind of look at if an area of the county is being underserved. So just to do a study to see how things are going, if there's any problems. So this is what that is, and I'll go through the methodology. So we pull the medical responses for the city of Gonzales, city of Soledad, city of Greenfield, and the city of King within the city limits. And we take them from AMR's First Watch online compliance utility. What that is AMR has a platform that pulls the response time information from the CAD. And then those calls are adjudicated by the EMS agency. So if there were a time that a unit forgot to go on scene or something like that, they have to show evidence of when they actually were on scene by AVL data or different things. And then the EMS agency reviews those. So we pull these calls because these calls have been adjudicated versus just raw data. The calls are, that's okay. The calls are sorted by compliant or late and calculating a straight percentage for each priority and overall. Just a reminder that response time is not a requirement that's at the city level. The goal is to review, ensure that no area or community of the county is underserved. So we'll go into City of Gonzales. So this one, usually we do biannually just for a 6-month period, but made sense to us to incorporate January since that was the end of AMR's old agreement, just to kind of wrap it up in a clean package. So for through July through the end of January, there were 338 responses, and that's combined responses for the city of Gonzales. 319 responses were compliant, which accounted for 94%, and 19 responses were late. We also do a breakdown of the priority 1, 2, and 3 calls. You can see, and I want to reiterate, interpret the call volume and the percentages with caution because there's very low call volume in some of these broken out priorities. So 90% compliant responses for priority 1, 96% compliant responses for priority 2, and 96 compliant responses for priority 3. We also ran the average response time across all priorities for the city of Gonzales, which was 12.3 minutes. The city of Gonzales is split into 2 zones. So 250 of these responses were within the yellow zone and 88 were within the orange. And just as a reminder, that their average response time was 12.3 minutes across all priorities. They're very close to meeting for their average response time, the most restrictive response time, which is priority 1 for yellow, which is 12 minutes, even though there were orange responses mixed in there. So the orange responses, the priority 1, just for reference, is a 16-minute response time. So they're actually doing an amazing job in Gonzales. So any questions on Gonzales? Okay, on to City of Soledad. So the City of Soledad, we exclude the Salinas Valley State Prison and CTF responses, so because they are considered to be within the city limits of Soledad, but to get kind of a better idea of the actual City of Soledad, we pulled those out. So there were 738 combined responses across the priorities, accounting for 94% of them being compliant. If you look at the priority 1, 2, and 3, they were all above 90% compliance for each priority. Average response time across all priorities for Soledad was 8.3 minutes, and 73% 731 responses were within the yellow zone and 7 were within orange. So well below the most restrictive response time in either of those zones, which would have been 12 minutes for priority 1. We account this too, and just kind of as information, there's an ambulance stationed in Soledad. And so you'll see the response times are a little farther in Gonzales. That's because they're usually responding from Soledad to Gonzales. And so they're going to be shorter in Soledad because they're responding to Soledad from Soledad most of the time. Any questions on Soledad? Okay. Oh, I missed Greenfield. Sorry about that. Okay. Okay, City of Greenfield. So 674 combined priority 1, 2, and 3 responses. Overall compliant responses accounted for 95%. For priority 1, you will say it was at 88% compliant. That still is doing quite well considering the low call volume. And again, there is not an ambulance stationed in Greenfield. They are usually responding from Soledad or King City, but primarily from Soledad. Priority 2 was at 97% and priority 3 was at 95%. Average response time across all priorities for Greenfield was 12.2 minutes, so very close to the priority 1 12-minute response, which is the most restrictive in that area. And all these responses were within the yellow zone. Any questions on Greenfield? Okay, move on to King City. There was a total of 426 combined responses, and that accounted, the compliant responses accounted for 95%. Breakdown of priority 1, 2, and 3, you'll see 90% for priority 1, 96% for priority 2, and 97% for priority 3. Average response time across all priorities was 9.1 minutes. Just pointing out that there is a unit stationed or an ambulance stationed in King City. So that's why the response times are going to be a little lower in that city. 247 responses were within the yellow zone and 179 were within orange. So quite a bit are in orange, and they are well below the priority 1 12-minute response time, which is the most restrictive out of both of those zones. So they're doing an amazing job in South County. Any questions?
Sorry, Kim, I missed, circling back to Greenfield, what was the calculated average response time that y'all had for?
It
Greenfield?
was 12.2 minutes.
Thank you so much.
Mhm. Okay, any questions? Okay, we're gonna move on to, this is my last one. Okay, do this. North County. So similar to, as Karina pulls that up, we do a, also to check and see if any area of the county is underserved, we do a North County response time study. We do this annually because there are more communities, so they spread the call volume a little thinner among the communities in North County. And so we do it at the end of each year. And I'm sorry, go ahead and. Okay, but I did add in January for this one as well. So it's a 13 months study because of wrapping up AMR's end of their old contract. Very similar methodology other than we're looking at the unincorporated communities of Aromas, Castroville, Las Lomas, Prunedale, Pajaro, Moss Landing, and Monte del Lago. And just a reminder, response time is not a requirement at the community level. We are doing this to ensure that no area or community of the county is underserved. So Aromas, there were, for that 13-month period, there were only 63 responses. So keep that in mind and interpret with caution when we look at priority 1. So overall, that accounted for 87% compliant responses. And for priority 1, the compliant responses were 80%, but there were only 20 calls total. So that you got to really take that into consideration. So 91% for priority 2 and 90% for priority 3. Average response time was 16 minutes. Most calls were in the orange response zone, which were 46 calls. The strictest response time in orange is 16 minutes for priority 1, and for yellow, it is 12. So they are on average meeting the orange priority 1 response time for aromas. Right, moving on to Castroville. So Castroville, and this one's interesting, total of 409 combined responses. And there was one call that was late, but it still wouldn't count it as any percentage. It basically said everything was at 100%. And so that goes for all priority 1, 2, and 3. They were only late to one call in all of Castroville in 2025 and January of 2026. Average response time in Castroville was 10.5 minutes. All responses were within the yellow zone. And again, the strictest response time in yellow is priority 1 at 12 minutes. Next slide. Las Lomas, total of 132 combined responses. Overall compliant responses accounted for 98%. Breakdown, priority 1 was at 95, priority 2 was at 100, and priority 3 was at 100. So there were only 2 late responses for that area in that 13-month period. Average response time is 14 minutes. All responses were within the orange zone. Reminder that strictest response time in orange is priority 1 with a 16-minute response time requirement. Ferndale. So largest call volume in North County, 1,374 calls. Overall, that accounted for 98% of them were compliant. For breaking down 1, 2, and 3, we had 98% for priority 1, 99 for priority 2, and 98 for priority 3. Average response time in Ferndale is 9 minutes. I just want to put it out there. They have 1 ambulance stationed in kind of the North County area, and that's Ferndale. So that's why they're going to have a lower response area. On some of the areas that kind of that border against Santa Cruz County, they do ask for mutual aid because they're going to be closer from Santa Cruz County from Watsonville. The overwhelming majority of the responses were in the yellow zone. Only 11 were in orange, and the strictest response time in yellow is 12 minutes for priority 1. For Pajaro, there were 308 combined responses. Compliant responses made up 95%. Priority 1 had 98%. Priority 2 had 94%, and priority 3 had 95%. Average response time was 15.7 minutes. All responses were within the orange zone, and the strictest response time in orange for priority 1 is 16 minutes. So they were below the strictest response time. Moss Landing. They had 74 combined responses. Compliant responses made up 96%. Priority 1, they were at 100%. They only had 4 calls, which is great and amazing. Priority 2 was at 96%, and priority 3 was at 93%. Average response time in Moss Landing was 12.6 minutes. Majority of these calls were in the yellow, which was 61. So 13 were in yellow, and so 13 were in orange. Strictest response time for yellow was 12 minutes for priority 1. So they were a little over the yellow, the strictest response time, but just keep in mind, this is averaging across all the response, all the priorities. Any questions on North County?
Kimberly, these are average response times, not the 90th percent as we were looking in the previous one. Okay, thank you.
And Kim, I'm sorry, could we circle back to Pajaro what the average calculated response was?
Yep. 15.7. Okay. I think that's all. Do I have anything else? No? Oh, good. Okay, thank you.
Thank you, Kim. Okay. All right, so, pardon me, I lost my place.
Will, I just have something on that. If we could get those reports emailed to us, That would be great rather than,
The county's report?
yeah, they weren't in the packet, so if we can get those,
Yeah.
the South County and North County reports. Great.
Yeah, yeah.
Thank you.
Absolutely.
Yeah, we wanted to provide the context before we sent them out, so, yeah. That now.
All right, so it looks like moving on to item E, EOA ambulance contract transition report. Deborah.
Yeah, thank you. So as a reminder, the new contract went live as of February 1st, 2026. There was a sort of flurry activity with CAD changes and the like the evening of the January 31st. So those all successfully went into place before the go live transition. Thank you to ECD staff for their work to get those in place. Much appreciated. With the new agreement, brings many additional hours into the system, brings new ambulances, type 3 ambulances, which hopefully you have seen on calls and out and about in the community responding to calls. Also brings a bariatric ambulance to the system, and then new cardiac monitors and some other clinical type equipment as well. So for the EMS agency, we're continuing to work with AMR on tying up a few loose ends around the implementation period. So customer service survey, some items related to First Watch, that sort of thing. So we'll provide more updates on those as they go live. We're also just wrapped up compliance reporting based on the old agreement and working with AMR to sort of fine tune and develop the reports for the first month and on the go forward for contract compliance based on the new agreement. Also still working on the clinical scorecard. We've got it up and running and functional and have been able to process some calls in it. We want to do some verification within ESO to make sure that the numbers flowing into First Watch make sense based on what we're seeing for the totality of PCRs in ESO. We're also continuing to work on the CCT services, in particular, the expanded scope paramedic services. So we've had a couple of different meetings with MDAC and the state related to our application for a LOSOP to expand the scope for AMR's paramedics. We've taken that back a couple times and we'll be taking it, hopefully what will be the third and final time to the meetings next week with MDAC. So more word on that as that moves forward. Finally, I will talk about nurse navigation. So we've held several working group meetings since the last EMCC meeting. 2 of the 4 working groups are now wrapped up and completed with their responsibilities. We've also held other individual meetings with ECD staff and the fire agencies, in particular discussing with the fire agencies their plans for response to calls that are navigated to nurses as far as whether or not to respond to those calls once it's been referred. And then if for some reason the nurse should request an ambulance response, whether they'd like to respond back to those calls. So we have 2 final working group meetings that are still on the calendar. One related to call flow process, which will solidify some protocols for AMR and work through some of those items that we discussed with the fire agencies. And then for community education, and that will be primarily related to finalizing educational materials about the services for the community and determining when we want to release those in relation to the go live date. So different communities that have implemented services have handled that differently, and we just need to reach a determination for here how we feel is best to move forward. From there, we'll work to establish a go live date. I think we've made some really good progress and are still hopeful to go live within the second quarter of 2026. So happy to answer any questions on anything anybody might have related to the ambulance agreement. And Mike and Will, if there's anything you'd like to add, by all means.
So Deborah, I have a few. On the nurse navigation piece, do we have policy direction to support that piece? It seems as though we might find ourselves in some conflicts when we get there and they still may be on the phone.
We're working on some of those things. Those are some of the final pieces that we'll be putting in place and getting those out for a public comment for an off-cycle adoption.
Okay, and those will be in place before it goes live, I would imagine.
Correct, yes.
Okay. Perfect. The second question is not related to nurse navigation, but does relate to some of the other features of the new contract, basically the BLS ambulances. Mm-hmm. With our special event cycles starting to come up with one of our bigger events with the CR Classic coming up in April, do we have any direction on BLS use in those special events?
What we have in policy currently is actually a part of the 2026 policy and protocol review cycle, and it's more related to the transition that would occur between, say, I'm a paramedic working on an ambulance with an EMT and I want to hand that patient off. So we don't have specific special event guidance, but we can certainly work on developing that if there's a need for that.
I think the concern for us would be, we have ALS working the event and BLS ambulance supporting the event. How does that work when we have initiated patient care to transfer that care back to the BLS ambulance, if that is appropriate?
Gotcha. Yeah, and sure.
To help a little bit with that, the event organizers can use whatever first aid services they choose, from, basic first aid, CPR people, all the way up to full ALS. And then, of course, some of the events that Laguna Seca have physicians on scene. As far as a BLS ambulance from within our system, that's a potential. But so far as I know, having reviewed all the medical plans, if they're looking for ALS, which they'd be looking for first response ALS from you, there's no anticipation of a BLS ambulance being there for that to be an issue. The only way you'd see a BLS person there at this point would be if somebody from out of the area came in as a special event first aid provider with non-transport. That's all that's really come through at this point. If they're looking for a BLS ambulance and ALS first response, there'd be a significant mismatch, and I don't think we'd even approve the plan.
Okay, so what you're saying is for special events within the county, BLS ambulances won't be allowed to work those events if an ambulance is requested?
That wasn't exactly what I said. What I said was, as far as the event goes, they can contract for whatever level of service. If it's a service that needs an ALS provider, which is why, again, Laguna Seca and Toro, your folks would be involved, it would be a mismatch to then have a BLS ambulance.
Okay, so how do we communicate that we'll staff when we're requested to staff special events, we're staffing them at the ALS level.
Mm-hmm.
So that triggers a ALS response or commitment from AMR. Is that what I'm hearing, or?
Not necessarily, but
Yeah, I'm confused at what you're saying.
right. So if an event needs an ambulance,
What does that mean?
that means that there's either, for our purposes, if you look at our special event policy, it means that if there's significant risk to the participants or the spectators, if they're, like Seattle Classic, it's a bicycle event. It's going to be crashes. They need medical there. They need ambulance there. Distance is another issue. So if someone's going to be at Lake San Antonio, due to the couple thousand people, there needs to be an ambulance there. If the event is such that they feel there's a need for a paramedic ambulance and they contract for a paramedic ambulance, all's fine. Doesn't, it's what we're doing now. If they want to contract with the BLS ambulance, we get a medical plan. Again, assuming we get the medical plan, we'll get a medical plan and we'll evaluate to ensure that the appropriate service is there. If the promoter organizer is requesting an ALS first response or first response at all, but then you go ALS, it probably needs an ALS ambulance. So for us to approve the plan, we wouldn't expect them to send a BLS ambulance if it's at that level of an event.
And I guess my inquiry isn't based on the minutia of what is staffing. My inquiry is ensuring that we have policy direction. So when we do have a BLS ambulance arrive to it with an ALS first response, how do we transfer care? That's
Yeah.
what I'm looking for.
Yeah. Yeah, I guess if I could,
Sorry, are we talking about transport from the event off scene?
Yeah, to the hospital.
That would be an ALS transport from the scene off sites or from the system. So we would transport off scene because we don't backfill from those events. So they would be transporting from the 911 system off site from the 911 system with an ALS response.
Okay, so if we have an a event.
So there would be an interface between, just as there is from a 911 call, right? So your ALS responders would be interfacing with the 911 system at that point.
Okay.
As they normally do.
So the BLS ambulance that's there wouldn't render.
I guess they would be rendering first aid with your crew members, and then the transport component would be done as it is normally on scene.
Okay.
Yeah.
So it isn't contemplated that the ALS first responder would assist the BLS ambulance to transport that patient to the hospital.
They would be transporting, my assumption would be that because we're the transport provider, and if the patient needs to be transported to CHOP, let's say, we would be transporting as we normally would and interface with your crew members as we normally do, transferring care from paramedic to paramedic and transporting to SVH or to CHOP.
Okay. So we really have two different scenarios, Wills. We have someone up in the stands that has a heart attack. You are staffing the event with BLS ambulances. We're staffing with an ALS response. We conduct our ALS response and start treatment. What you're saying is we would have to request a ALS ambulance from the 911 system to then go out to Laguna Seca to transport that person to the hospital, rather than using the BLS ambulance along with our ALS first response to make that transport.
I don't know how many Laguna Seca events have ever had a BLS ambulance to begin with, or.
We've never had BLS ambulances in the system, so that's why I'm asking. This is a new wrinkle that
I hear you. No, I totally hear you, but in the past, the events never require, or like Steve said, are sanctioned or whatever that, I'm sorry, I'm probably not using the right verbiage, but they don't allow for a BLS ambulance on scene, but.
Can I ask, are you asking, will the policy allow for your paramedic to jump on AMR's ambulance in the event you need that ALS transfer?
I'm just trying to figure out, Jody, how this all going to work.
Yeah.
You know, I heard Will saying that they're not going to have BLS ambulance at Laguna Seca, which solves our problem. But then I also heard Steve say they may. So I don't know what the answer is. I just want clear direction for our paramedics to understand, okay, if they have the idea that they're going to jump on the ambulance and make the transport because of the critical nature of the incident, or we're going to wait for another ambulance to come into that 12-minute response zone to then transport. That's what I'm trying to figure out.
Yeah, I guess I thought that if the county, I guess it's part of the emergency plan, right? So if the county's emergency plan allows for the BLS there, then we'd have to have that policy in place. If the county's emergency plan does not allow for it, then I totally hear what you're saying. But in my experience, any event at Laguna Seca, they've never allowed for a BLS ambulance to be there. The contractor or the event planners have always asked for ALS services.
Can I ask it a different way? So how does that differ when an engine is on scene? Well, if you're asking for a second paramedic from an engine to jump on an ambulance, could you use that same policy?
Well, you still
Probably
have
not,
the
because it's
providers already
BLS.
providing it. You know, so that's the first wrinkle. And then the second would be, you know, you have the BLS, and if you don't have BLS at Laguna Seca, it's at another special event that requested BLS ambulance. Our paramedics initiate care. How do we transfer that to the BLS? Because I don't think it's clear in policy right now how to do that. Because that would be transferring care to a lower level, right?
I guess, again, are you,
So yeah, this has come up in a couple of meetings that I was asking to question you guys very similar things. So the first was in our district, you know, would BLS ambulances be part of our district? And we were said not for at least 6 months at the time. So yeah, no, and this is the other part of it. It was of special events. So our understanding is that those BLS ambulances are 100% BLS. They will not be staffed with ALS equipment. So like the chief's saying, if it's put into the system and they say, you know what, the event does allow for a BLS ambulance, the second that we start any ALS interventions or just an ALS call, so you get a chest pain call, it's like we would have to call for a new ambulance for an ALS ambulance right away. Or are we expected to say, I'm taking this call and I'm using your ambulance, which is BLS equipped, which places our engines out of service or whatever equipment we got because we have to take all our ALS gear with us on that call. So yeah, I'm sure Chief's just looking for a policy that drives when we will have if a BLS ambulance is allowed to participate in a special event, what do we have in place to make sure it runs smoothly? Chief, is that pretty much?
I think it's good practice to have the policy in place regardless, because eventually you're going to have these two meet. And do we have a plan in place that everyone understands exactly what the rules are? So that's what I'm looking for.
And I guess if I could, yeah, I agree with what Chief Lindquist said as far as, our message consistently has been that there will not be BLS ambulances in the system until such time as we can review the data related to their impact on interfacility transfers. If we make a decision that we want to move in the direction of implementing them within the system and that it's in the best interest of the EMS system, that at that point we will have conversations with our stakeholders. We'll develop the policies necessary to do that. So there won't be any surprise there, BLS ambulances unexpectedly responding within the 911 system. And I think Chief Sargenti raises a good point as well, as far as within the new agreement, there is a rate established for BLS standby ambulances. So we should have the policies in place to plan for that. So that's something that we can work on for what that might look like. Hopefully that answers the question.
All right, moving on to item F, EMCC member requirements. Steve.
This one's pretty simple and easy for those who, I think everybody's completed their Form 700. If you haven't, please get that done. But also for the member requirements, we are coming up to the end of the cycle. For half of the membership of this group, we'll be reaching out to you to obtain a recommendation if you represent a group such as fire chiefs or law, and it's your cycle. I don't have that information off the top of my head. We'll need recommendation from your group for you to continue, or if you'd like to step down and have someone else, we'll need the new person. Earlier is better, so we can get them seated by July 1. We'll need to take the nominations to the board at least in June, so we can have people for the July meeting. That's really it. Otherwise, we really appreciate having all of you here to represent your constituent groups.
All right, moving on to new business, item A, EMS annual plan. Deborah.
So I spoke a little bit about this earlier. I would just add that the intent was to distribute a copy of the plan with the EMCC agenda packet. It doesn't appear that that was included, so we will send that separately after this meeting. And we'll be happy to take any questions or comments, I guess, at the next meeting related to that.
All right, item B, EMCC annual report to the board. Steve.
Pass those down. Pass those around that way. Actually, I should have probably onto that. So as we discussed at the last meeting, this body is charged with advising the EMS agency as well as the Board of Supervisors. So we have an annual report to the Board of Supervisors to let them know how this body's been doing. The EMS agency was asked to put together a draft for this committee to review. And so I've provided a copy today, mostly to help show you how it's formatted and what we thought we should try to do to help move this along. So clearly at the beginning of the report is, what the EMCC is supposed to do. That's section 1. Section 2 is a list of the membership, and you'll see, of course, there's some membership changes throughout the year. Item 3 is the activities of the EMCC. This is what we've been discussing, and it's broken down kind of how the the agendas are broken down. First off, there's a list of the reports that this body receives. We appreciate this body reviewing, what happens within the EMS system. And you will see from that, after the report section, you will see item 2, which is discussion and action items. And so from the reports, we took some of that and we've chatted about it, we've talked about it, and provided some recommendations to the EMS system that then came back into the reports. So you might see a little overlap on some of those, but the materials designed to show, here's the reports and what you guys have been looking at, because you're, again, reviewing the, what's happening in the EMS system, in the county of Monterey. And then as far as the discussion and action items are things that, may have got a little more attention, specific items. And again, I tried to highlight the ones that we discussed most of the year. And then we have things that the EMCC reviewed and endorsed. And then there's a little bit about the subcommittees that report to this body. So that's the general structure of this report. The 2 things that we'll also be adding is the updated cover page, which has the nice, EMS logo on it, and then also the report letter from the chair, which will highlight the first page of the report, and we'll be working on that. So that's the general report to the Board of Supervisors, how it's laid out. The items that, as I went through the meeting minutes, stood out to me as being of greatest import and of potential interest to the board in the actions of this body. And with that, I'm open to any comments and questions, concerns, anything you'd like to add. This is your guys' report. So, we can take as much or as little time. Again, I wanted to make sure you guys had the context before you guys had it in your hands and go, I don't understand it. So not looking for a completed report necessarily today, but happy to answer any questions or comments. And also, please look this report over and get back to me with anything that you could say, hey, we didn't, we talked about this. I'd really like to see it in the report, or if you have questions about how it's addressed in the report, so we can bring something back for your guys' endorsement to take to the Board of Supervisors. It'll be tight, maybe July, but that'll be, I'm sorry, May, with the EMS week conjunction. It'll be a little tight. We may not be able to make it, but we can try. So comments, questions? Brickbats, I don't care. Again, it's your guys' report. Happy to help as secretary of this body to put some things together for your review.
So Steve, I guess if you could send that out electronically to the group and then give them an opportunity to review with a little more time and provide some feedback if they have any, that would be
Oh,
great.
absolutely. Again, let me know so we can put it together, a more finalized draft with what you guys would like to see in it. And then we can hopefully endorse next meeting in May. And we'll have a letter from the chair too. All right, well, thank you.
Thank you, Steve. All right, item C, EMCC nominations for chair, vice chair. Steve.
Again, we're going to have a rotation with July, which means also potential for a new chair in July, but we will need to confirm that and also a vice chair. History of this is that the chair sometimes says, hey, I'd like to stay. We've seen that. We've also said that chair felt like they've enjoyed their year and want to move on to be just a member. And historically, the vice chair has moved up to the chair, but still needs to be elected. Current vice chair is Chief Chris Borkin.
I heard the chair stays indefinitely.
That's for you guys to determine. I'm just giving the history, the background, and that next next meeting, we will be looking for the group to vote for the chair. It's just, today's the day to have a discussion. If anybody would like to throw their hat in the ring, try to nudge ahead of Chief Borkin.
It wouldn't be tough. I just don't know a lot about anything that we're talking about. So that's okay.
And then, you think we know what we're talking? No, I'm kidding. You've asked in the past for something of an EMS overview so that you can be more familiar with EMS in Monterey County, and we're actually working on that. So we want to bring this group. We know we'll have a new citizen rep, even a newer citizen rep coming on. Jody's hoping for another new rep. So yes, it's time for us to do that for those who, are not actively engaged in, the day-to-day of the EMS system. We are putting together something that should highlight the EMS system for Monterey, EMS in general. And I will say, most people don't know, but this year, 40th anniversary of paramedics in the county of Monterey. In case you're wondering the date, it's September 2nd, 1986 is when we had our first paramedic ambulance on in the county. I'm not going to ask anybody if they were around at the time, but I'd worked here as an EMT, went to paramedic school, and I was a paramedic on an ambulance in Santa Cruz the day before we went paramedic here. So, but anyways, it's 40 years for paramedics in this county.
So historically, Harry takes care of this right now, right?
Harry offered his
We need
guidance, yes.
Harry today so he can nominate the next two chair and vice chairs. But let me start, Will, are you willing to serve another 2 years or another year or whatever it is?
Yeah, definitely.
Okay, well, I'm going to start by nominating him then.
It's a discussion. Nomination will come next.
Oh, okay. Discussion?
We want to know who we're going to be looking at so
Oh.
that when we're not having all the discussion next time, we, know who's interested. Well, again, what we're looking for is if anybody's interested, and then we'll have nominations, and people who are saying, yes, I'd like to, or I'd like to decline, next time. But this will help us get it on as an action item. But you're
Anybody else?
Would you be interested in remaining as vice chair? Until the point that we follow the past and move up to chair? Okay, thank you.
And I'm sorry, then, so next meeting, we
Next
do
meeting,
the
we'll-
formalities of everything with
Yeah.
the names, the lists of people that we
Yes,
voluntold to be on the.
yes. If anybody is interested, you still have the opportunity at the next meeting.
Yes, sir. Okay.
We wanted to ensure that there was somebody kind of interested, so when we bring an action item, there's
Totally understand.
something we can take an action on.
Okay, alrighty. I understand. Okay.
Because if we didn't, you guys wouldn't show up at the next meeting.
Okay, so, all right, so moving on to, sorry, so any other discussion about that then? No. All right, moving on to item D, electronic application for EMT certification and paramedic accreditation. Steve.
We are very happy to report that the electronic program for submitting EMT certification and paramedic accreditation applications is in place. We've selected Certami as our provider for this system, and generally, it seems to be launched really well. We started at the beginning of February, transitioned over to the electronic applications. At this point, we are no longer taking paper applications. We had a couple little bumps in the road. as expected. One is we didn't create a workflow for people who currently had an EMT certificate and wanted to come to Monterey County or the County of Monterey and obtain their renewal here. We've since created that workflow. It's now available on our website. So with the main issue being people forgetting what email address they used that we preloaded for them to access their account, it's been pretty easy going, it seems, for the applicants. Some of the transition for the paramedic supervisors who approve and validate that the paramedic is actually working for their organization has had some hiccups, but I think we've solved almost all of those. And we think, and the feedback we're getting is people like the online application process, feel it's a very simple to use. And from our end, we are getting used to it also. And I think we're going to see a shorter processing time for the applications for certification accreditation. So that's how it's shaping up. But does anyone have any questions about this?
For paramedics, will this process override paramedics who are with multiple services having to accredit multiple times?
It's going to change it a little bit. If a paramedic has multiple paramedic employers, they will submit a single application and then send each the supervisor that's designated, they'll receive an email to say, yes, they work for us, and they get the one application, to take care of everything for them. So we've simplified that a little bit.
Thank you. All right. All right, so moving on to announcements for the good of the order. Any member of the committee may make announcements or comments. The EMCC may not discuss or take any action on any item raised during announcements, except to decide whether or not to place the matter on a subsequent agenda. Any announcements?
I guess, as many of you saw earlier this week, there was a significant structure fire on early Monday morning. And it involved a large number of response by EMS resources. And I just want to take a minute to acknowledge the communication center staff that worked to coordinate those resources and all of the coordination that took place on scene to handle a large number of patients, get them off the scene in a timely manner and transported to definitive care both in and outside of the county, all while an ambulance accident happened in the midst of it. So big effort to pull all of that off and get everything handled appropriately. And we appreciate that effort. So to acknowledge that.
Thank you, Deborah. All right, next meeting is Wednesday, May 13th, 2026 at 10:30. Thank you.